All right, good evening and welcome again to PDactive's Ask the Experts Roundtable. My name is Todd Morrish and Monique Buffler and I will be your moderators this evening. Give a hi, Monique. You're actually coming across as Events Committee right now, but that's her alias. So we have a lot to cover in this meeting and this evening and only 90 minutes to squeeze it into, so I'm going to abbreviate my usual preamble. But before we introduce our panelists, we do just have a few quick points to raise. If you are new to PDactive, by all means, check out our plethora of movement classes and support groups and other speaker events. You can learn more about these on our website, and Monique will paste that URL into our Zoom chat window now. If you're not familiar with Zoom chat, it's available as a tool on the toolbar at the bottom of your Zoom screen. If you hover over the bottom of your Zoom screen, you see all those neat buttons, one of those is chat. We will be sending you information through the chat, and if you have questions that you would like to send us, you can send them through the chat, or you can just raise your hand like in school in the old days. And alternatively, there is a little raise your hand feature in Zoom if you know how to use that. So keep your eyes on the chat. One other quick point about chat while I'm on this topic. If you've got the chat window open, you'll find a very small couple of 3 dots down in the bottom right-hand corner of your chat window. If you click on that, there's an option to save chat. So at the end of the conversation, at the end of the hour and a half, I will try to remember, Monique and I will try to remember to remind you to save the chat if it's important to you. It will have all the questions that folks have posed. It will also have the different URLs and email addresses that we're sending across to you. Okay. Whether you're new to PDactive or a seasoned vet, we enthusiastically invite you to attend our PDactive annual picnic, taking place Sunday, October 23rd, from 1 o'clock to 3:30 p.m. at Live Oak Park in Berkeley. We had, after a long COVID break, we had our last picnic at the same site. So if you were there last year, then it's the same location. We'd love to see you guys out there. Monique will paste that into the chat for you guys to record in your calendars also, and keep your eyes on the newsletter for more information on that too. For this event, you are all currently on mute. If you're not, we will probably put you on mute just to save the screaming dogs and barking dogs and screaming babies effect. Once our speakers have been introduced, each will walk through a brief PowerPoint presentation. We will keep you all on mute during the presentations to avoid interruptions. Following those presentations, we will have an extended Q&A window. Both presentations will be posted in their entirety on our website, and we'll send you that URL after the fact. So all of you will be receiving a follow-up email after this event in the next day or two, and they'll have key information in it, including the URL to the presentations. If you, let's see, I mentioned that already. There's another feature in Zoom you should be familiar with, and that is the speaker mode. So there's another small link in the upper right-hand corner of your Zoom window called View that allows you to select the speaker mode or the gallery mode or the immersive mode. I have no idea what the immersive mode is, so let's not go there. But if you click speaker, that's an option for you to see the current speaker featured on your screen instead of 25 or 30 different little thumbnails of all of our faces. Does that make sense? So if you're not familiar with that, give it a go. Finally, PDactive depends on donations to bring programs like this to our members free of charge, and we certainly remain grateful for your contributions. If you have not yet had a chance to make the suggested registration donation of $10 or $15 for this roundtable, we will paste that link into the chat feature now, and you're probably all familiar with where to find that on the pdactive.org website as well. So thank you very much for your continued donations. And now, without further delay, PDactive is pleased to introduce to you our panelists for today's roundtable. Alyssa Rome, we're going to call her, she goes by Lyssa. Alyssa Rome, say hi, Alyssa, wherever you are. There you are, in the middle down there. Julie Hicks, thanks, Julie. And Janelle Reinelt, there's Janelle. I'm going to give you a brief introduction to these folks, and they're going to expand that if they'd like to later, but Julie Hicks is a speech-language pathologist providing outpatient neurologic rehabilitative care at the Stanford Neuroscience Health Center. She is also a clinical lecturer and practicum supervisor for the Department of Communication Sciences and Disorders faculty at California State University, East Bay. Her clinical and research interests include management of communication and swallowing disorders associated with neurodegenerative conditions such as Parkinson's disease. She has previously worked for the VA Palo Alto Healthcare System and Norman Fixel Institute for Neurological Diseases in Gainesville, Florida. She has presented at state, national, and international conventions on rehabilitation topics for patients with movement disorders. Read more about Julie at a website that we can post in a moment here on your chat window. And let's see, let me find my other, Lyssa. Alyssa, who goes by Lyssa, is a speech language pathologist who specializes in holistic person-centered treatment for adults with neurogenic communication, cognition, and swallowing disorders. Her clinical areas of specialization are Parkinson's and stroke. She is a certified provider of LSVT Loud and Speak Out, which I'm sure we're going to learn more about from Lyssa soon. Treatment programs for people with communication problems due to PD and related neurological conditions, and is a 2022 Parkinson's Voice Project grant recipient. She sees clients in her private practice and at the Aphasia Center of California, where she facilitates communication groups. She has also worked in hospital, acute rehab, skilled nursing, and continuum of care settings. Prior to becoming a speech therapist, Lyssa was a public radio journalist, editor, and podcast producer. Before I get to Janelle, I want to let you know that Lyssa will be speaking to us today on the speech and communication, and Julie will be speaking to us on swallowing. Finally, there's hold on a second. There's one other subtopic often lumped together with speech, voice, swallowing, and that is cognition. In order to adequately cover the primary three topics in our session today, we will save cognition for another session. We want to make sure we cover the other three topics adequately. If you have any questions specifically about cognition, you may submit those in the Q&A while we're there, and we will try to address those time permitting. Finally, and I'm sorry, Janelle, to save you to the end, but Janelle Reinelt is our third panelist. Janelle, you may recognize as a PD active member who does not have PD herself, but she and her husband, Jerry, who does have PD, have utilized Lyssa's services in the past. Janelle will not be presenting today. However, she looks forward to fielding your questions from her and Jerry's valuable client perspective. All right. That is it. Without further ado, I will turn the mic over to Lyssa. She will start with her presentation, and then we'll take a short pause and change over to Julie's. Right. Lyssa, if you want to share a screen and jump on it, please feel free to add any more to the introduction, Lyssa, or just jump right into the deck.
Okay, thank you, Todd. I'm going to try to share my screen now. So let's see. All right. Thank you so much for having me. I'm really looking forward to talking with you all about, and I'm going to be focusing on speech, primarily speech and voice and communication in Parkinson's. But like Julie, I also help people with swallowing and cognition, and that's part of the range of issues that speech therapists help people with. Todd already went over this, so I'm not going to repeat it, but those, again, are my areas of interest. I focus on helping adults with neurogenic, meaning brain-based, communication, cognition, and swallowing difficulties. Okay, so speech problems are really common for people with Parkinson's, and the research shows us that up to 90% of people with PD experience difficulty with their speech at some point.
Okay, I got this.
Sorry, was there a comment? No, okay. There's a range, so some of the studies say around 70%, but more of the studies point to the higher end of that range, like around 90%. And those changes in speech can start early on in PD, but they may be subtle in the early stages. There's even been some research suggesting that early speech changes could be used as a potential biomarker for Parkinson's, meaning that subtle changes might be an early sort of red flag that someone might be developing PD. But the onset of the timing of the onset and the severity of speech changes what those speech changes sound like really varies from person to person. So it's definitely not uniform, and it doesn't happen in the same way or at the same time for everyone. All right. Okay. So some common communication difficulties that people will notice with PD are a softer or quieter speech, slurred or imprecise articulation. So maybe that could sound like mumbling for some people, speaking too quickly or speeding up over the course of a conversation or over the course of a sentence, having a hoarse or a weak voice. Those are all really common presentations of the speech difficulties that people have with Parkinson's. But I think that another common difficulty that arises, and for some people this is the first thing that they notice, is the fact that often people will start getting a lot of requests to speak up or to repeat themselves. And the reason that that is important to note, I think, when we're talking in general about the sorts of symptoms that people have, is that one of the effects of Parkinson's on speech is that people's ability to accurately self-monitor their own speech in real time is reduced. So someone might speak quietly, too quietly, but feel like they're speaking at a totally normal volume. So a common thing that people will say is, my speech feels fine, but my spouse needs a hearing aid. They're constantly asking me to speak up. And for many people, older, and especially older people with PD, their spouse might need a hearing aid. But often it's actually that the person with Parkinson's is speaking more quietly, but is unable to feel that they're speaking more quietly. So to them, it feels like they're speaking normally. And I'm going to come back to that later on. Another thing is that people might, as a result of some of these difficulties, participate less in the kinds of communication that they used to participate in. So for example, someone might say, well, I used to talk on the phone a lot, but I find myself speaking on the phone less because people are always asking me to repeat myself. Or they might find that they are less likely to speak up in conversations with friends or with family because people don't seem to understand, or they get ignored, or people are always leaning in and trying to hear them. So I want to talk now about some medical terms that are associated with the communication problems in Parkinson's, and that you might see if you look in your medical chart. So if you look at, your after visit summary or your neurologist note, you might find these terms, and so I want to define them. The first one is dysphonia. The root of the word phone, like phonate, is voicing. So dysphonia is a medical term for a voice problem. In Parkinson's, the specific kind of dysphonia that we often hear is hypophonia, which means a quiet or a weak voice, and hypo meaning not enough. The illustration here is an illustration of the vocal folds, also known as the vocal cords, and those sit in the throat here, kind of under the thyroid or Adam's apple, and your vocal folds open here. For example, when you breathe in and out, down here is the airway. The trachea goes down to your lungs. And then your vocal folds close, for example, to protect your airway when you swallow. And Julie, I'm sure, will touch on this as well when she talks about swallowing problems. When you use your voice, your vocal folds are vibrating against each other, so they're opening and closing. All right. Another word that you might see or hear is the word dysarthria. And that's the name for a neurogenic or brain-based speech problem that results in unclear speech. So dysarthria is caused by neurological diseases or damage to the brain, and it can result in like weakness, slowness, difficulty coordinating or controlling the muscles that we use for speech. And there are quite a few different kinds of dysarthria. And those different kinds of dysarthria, first of all, sound different to one another, but they're also associated with different disease processes or places in the brain that have been damaged. So someone who has dysarthria, say, due to ALS or due to cerebral palsy, will sound different than someone who has dysarthria from a stroke or a traumatic brain injury. The kind of dysarthria that is associated with Parkinson's is called hypokinetic dysarthria. So hypo, again, small or not enough, kinetic, movement. So hypokinetic dysarthria is a dysarthria that's associated with smaller movements. And the list of symptoms of hypokinetic dysarthria are the same symptoms that I was talking about earlier, the things that people will notice about their speech. So reduced loudness, meaning people talk too quietly or they have really soft speech. Imprecise articulation, like mumbling, or maybe a little bit slurred. Monotone speech, meaning people's speech might sound a little flat without a lot of pitch variation up and down, or loudness variation, or without adequate stress or intonation. People also often have rate problems, meaning that they typically in Parkinson's will speak too fast or speed up while they're speaking. Or they might have periods of time when their speech is pretty normal in terms of the speed, and then they might speed up all of a sudden. People also might have dysphonia, that hoarse or breathy or weak voice. And then sometimes people will have stuttering-like repetitions, where they might say a whole word or a phrase more than once. Not everyone who has hypokinetic dysarthria has all of these symptoms, and there actually are some more symptoms that are less common than these. But these are the kinds of problems that we might hear in someone's speech that would help diagnose hypokinetic dysarthria. So I want to talk a little bit about why some of these speech problems happen and relate the speech problems that we see in Parkinson's to the motor problems that people are often a little bit more, or that are a little bit more obvious, and people are often a little bit more familiar. So one thing to know is that dopamine is very important in our ability to plan and control automatic movements. And speech is one of the most highly automated human behaviors, and also one of the most complex behaviors. We have to coordinate a bunch of different systems and a lot of different muscles very quickly in order to speak clearly. And in order to do that, it has to be pretty automatic. So when you don't have enough dopamine and then some of those automatic, some of the automatic control of the speech is a little bit reduced, and it can cause some of the problems that I talked about on the previous slide. Another example of something you might be familiar with from the motor symptoms is rigidity. So one example of how that shows up in speech would be rigidity of the muscles of the larynx, like the vocal folds, the voice box, which can lead to the vocal folds bowing, meaning there's kind of a gap. They don't meet cleanly in the middle, but they might have a little gap in them. And they are not closing quite all the way. And that can lead to air escaping while people are talking, which makes the voice sound breathy and can make it hard to be loud. Another example is hypokinesia, so smaller movement, and bradykinesia, or slow movement of the mouth, the lips, the tongue, all the articulators, as we call them. That leads to problems producing clear speech and difficulty being understood. Another aspect of these problems that I've been describing is that there are some sensory motor impairments in Parkinson's that contribute to the difficulty people have, or are really behind the difficulty people have accurately monitoring their speech in real time. So again, what feels like normal loudness is often actually too quiet. And when people do speak at normal loudness, it can feel like they're shouting. So you get this kind of mismatch between the actual loudness and the perception of loudness, or the perception of how effortful speech is. And one interesting thing to note is that frequently people with PD have a hard time accurately monitoring their speech as they're speaking, but if they listen to a recording of themselves, then they might be able to recognize more easily that their voice is too quiet. And then I wanted to touch on hypomimia, or facial masking. And it's not exactly speech, but it is communication, because our facial expressions help us communicate how we're feeling, how we're responding in a conversation to others. And so masking can lead to difficulty with social communication. And there have been a few studies that show some positive impact on facial masking from some of the intensive speech therapy techniques that we sometimes do with people with PD. There's not a lot of research on this, but there are a few studies that indicate there might be some benefit there. Okay. So I'm going to have a sip of water. Next, I want to talk about what you can do about it. So speech therapy starts with an assessment. And we do an assessment to determine whether you have a speech and voice disorder, if one exists, and then also come up with a plan. And also, actually, in addition, we describe what that speech or voice disorder is. In an assessment, we start by reviewing the medical chart, looking at doctor's notes, taking a history. So when did you first start noticing this? What do you notice? That sort of thing. The speech therapist will do a cranial nerve exam to see how the muscles are working for speech. And then we ask people to do a series of speech tasks, such as reading or talking about having a conversation, saying certain words, and then we'll have people do non-speech tasks. Non-speech tasks are things like saying "ah" for a long time and seeing how long you can hold it, or saying a certain sound over and over and over again. And when we ask people to do those things, we can take measurements. So we can see how loud or soft people are, how quickly they're able to do certain things with their mouth, what their pitch range is, so how high can they take their voice, how low, that kind of thing. And then part of the assessment usually is also asking people to describe and rate their own perceptions of their speech or their voice and how it impacts them in their life. As part of that, we sometimes also ask for input from family members. So depending on both sort of what we see and hear and observe during the assessment, and then also depending on what the sort of goals of speech therapy are, we often will refer to an otolaryngologist, which is an ear, nose, and throat doctor, or ENT. And they can, and actually some speech therapists as well in certain settings are able to do this also, usually in a hospital clinic. They can put a camera either up through like a camera that's on a flexible tube up through the nose to look down at the vocal folds or the larynx from above, so looking down into your throat, or sometimes through the mouth to look at the vocal folds and the area around them and rule out other voice problems. So it is possible to have a voice or speech problem from Parkinson's and then something else as well. And we want to make sure that we are able to treat what's actually causing the voice and speech problem. Also, some of the treatments that I'll talk about are very intensive. So if someone has, say, vocal nodules or something else going on with their vocal folds, we don't want them to do intensive voice therapy until that other problem has been taken care of. All right. On to treatment. So overall, the goal is to help people maintain the best communication they possibly can at every stage of the disease. And I think that is important because we want to, hold on. Actually, I should say next that early intervention is important because we want to help people slow the decline of their vocal function or their speech function. And sometimes what we're trying to do is helping them restore speech function, but it's always easier to slow progression and to help people maintain their current function as long as possible, rather than to help people improve function that has already declined. So that's why early intervention is important. But that said, it is really never too late. So speech therapists help people from very early after diagnosis all the way through the very end stages of the disease. And we can help people with communication at every single point along that very wide spectrum. And I would say that another important thing to know is that speech therapy, whether it's for Parkinson's or any other condition, should always be person-centered. So it should be individualized to the person with the speech or the communication problem. And it should be about more than just kind of quote unquote fixing the problem, but also about helping people or taking into account people's goals or their preferences, their needs, who else they're communicating with. So I think that is something to know. All right. There are a number of different approaches to treatment for PD, for the speech problems of PD. And two behavioral approaches that you may have heard of are LSVT Loud and Speak Out. And these are standardized programs. LSVT stands for Lee Silverman Voice Treatment. And Lee Silverman was a woman with Parkinson's, so it's named after her. It is very well researched. So they've done a lot of studies about it. That doesn't necessarily mean it's the best program or the only program that works. It's just the one that has the most studies behind it. Speak Out is developed and run by the Parkinson Voice Project in Texas, so you may have heard of that one. Both of these programs, while they're standardized and follow a specific protocol, they do allow for some sort of individual, you can individualize them as well to some extent, but they're always intense. So LSVT Loud is done in at least 16 sessions over 4 weeks. So 4 times a week for 4 weeks for an hour each time, plus daily exercise, and throughout the entire program and beyond. Speak Out is a little bit less intense. It's 3 days, typically 3 days a week for 4 weeks, also with homework and exercise each day in addition to speech therapy and in between on the days that you don't have speech therapy. So those both, they both can be effective and great choices for many people, but for some people that's going to be way too much. Some settings don't allow for that kind of level of intensity, and not everyone needs that specifically. Also, there are some speech therapists who would rather than following those protocols, they might draw on what they consider to be sort of the best aspects of each of them and kind of put them together. When people do that and kind of go off script, they can't really call it, say, LSVT Loud or Speak Out, even though they might be borrowing some components of those programs. So those are 2 options, but they're not the only options. And they're very exercise-based. So there are a lot of voice exercises, and then the idea is that by using certain cues, for LSVT Loud, the cue is loud. For Speak Out, the cue is intent. You use those cues to carry over this new, stronger voice into everyday life and everyday conversations through a series of exercises. All right. But they're not the only ways to go, and they're not the only things that people need. So sometimes if breath support for speech is a particular issue, then people might need to strengthen the muscles they use for breathing. So speech therapists can help people using respiratory muscle strength training. Usually people will use a device for that, a device that you breathe through, either in or out, depending on the person's particular needs. And that can be helpful for support, for developing better breath support for speech. And that should be done with supervision. You need a doctor to make sure that you don't have that there are no contraindications. So it's not something you should do on your own. And Julie actually may touch on that. It's also sometimes used to address some swallowing related breathing concerns. Another treatment area is personal amplification devices. So sometimes people will use a microphone with a speaker, and that will make them louder, and hopefully people can understand them better without the intensive sort of behavioral therapy. In addition, there are some other wearable devices. So one that you might have heard of is called a Speech Vive, and you wear it over one ear. And when you're speaking, it puts some sort of low-level background chatter noise into your ear. And that takes advantage of the fact that when people hear background noise, they will naturally get a little louder. So that's an option for some people, particularly if the behavioral interventions are not a good choice for them. That device is pretty expensive. I think it's like around $3,500 the last I checked, and it's not currently covered by insurance or Medicare. Another thing that speech therapists might work on with people are pacing techniques. So if someone's speech is really, really fast, and that is the primary problem in the way of their being understood, for some people, one approach would be to use, say, a pacing board or some method of slowing them down. Pacing can be addressed as well through some of the more behavioral kinds of interventions. And last on this list anyways, are environmental modifications. So speech therapists often work with people in a way that involves their communication partners and their environment. So for example, it is really hard to be heard in a loud restaurant. And it's really hard to be heard if your TV is on in the background all the time. So some small changes in the environment can make it easier for people around you to understand. Similarly, like sitting so that you're talking to someone face to face can really help, so people can see your mouth when you're talking. Making sure that the lighting is good. There are all kinds of little tweaks to the environment that can promote being understood. Hang on.
Hey, Lyssa, let me just jump in with a quick time check. You're in the real meat of the matter here on treatment, so I don't want to cheat that, but we'll wrap up soon and move over to Julie.
I'm almost done.
Great, thank you.
Okay, so I want to say that speech therapy is not typically just like you see a speech therapist for a little while and then you're done. It's more like a dental model where you go to the dentist every 6 months, they clean your teeth, they fix any problems, and then you go home and you brush your teeth and you floss, and that's how you take care of your teeth. Same thing with speech and voice and Parkinson's. You go to a speech therapist, you learn some techniques, you improve your speech function, and then you have to exercise and keep it up in order to maintain your progress. And even if you're doing your exercises diligently, you probably will need to go back as your disease progresses and get a little tune-up or address any new problems that have come up, or kind of get back on track with exercise and keep going. So it's an ongoing relationship, and as with so many other things in Parkinson's, exercise is really important. And here's my final slide. So what I've given you a lot of information. This is a really big topic for a short amount of time. So thank you for hanging in there with me. I want you to remember that speech changes are really, really common in Parkinson's, and they can start early on in the disease process. Things to look out for are quiet speech, weak or breathy or hoarse voice, difficulty with articulation and speaking too quickly, but also requests for repetition. So that's a red flag. If you find that the people around you are asking you to repeat yourself, that probably means that it's time to get an assessment to see if there's a problem. Early intervention is preferable, so it's really great to get started before it becomes a big problem. And it is never too late. There's always something that we can do to help people communicate more easily. And finally, as we said at the beginning, speech therapists help with more than just speech. We also help people with cognition, which again, we're not covering today, and swallowing, which Julie will cover. So I am happy, we'll be answering questions here today, but I'm also happy to, if you have a follow-up question or something that occurs to you later on, I'm happy to answer questions via email as well. And
Terrific.
My email will be shared.
Terrific, and we'll put that into the chat. Before you stop sharing, do me one favor, Lyssa. Yeah. Bring that back up and go to your second slide before we have Julie start. I wanted to just do a very quick, purely voluntary straw poll here to see what folks in our community are suffering from. So I wanted to see the typical symptoms there. There you go. That's good. So just by way of hand, and this is voluntary. If you're not comfortable doing this, please don't, but show us how many of us are out there are suffering from softer or quieter speech. Some more than half. I'm going to scroll through the roster here. Yeah. Okay. Slurred or imprecise articulation, like me a little bit. Also, I knew this was an important topic to you guys. You all put it down in the survey, so good for you. Speaking too fast or speeding up, pace issues. Not so much. Okay, that's a lower. Hoarse or weak voice. I definitely have this. Okay, some of you. Requests to speak up or repeat. Lots of us. Me too. Finally, before we move on to Julie, how many of us are having challenges with swallowing? Let's say half again. And Lyssa mentioned one other symptom that's common in this space, and that is facial masking. Anyone out there struggling with or showing signs of facial masking? All right. Well, thank you for that. That gives our speakers a little bit of the lay of the land. Lyssa, go ahead and unshare, and I'll stop the recording. I do apologize.